Namaste and greetings. I, Tanu Palewal, researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, Nai Delhi, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the third day of women's sexual and reproductive health across a lifetime. An online national summer school program, a 4-day immersive online certificate training course. This training program is organized by IMPRI, Gender Impact Study Center, GISC. The chairs of the program are Professor Vibhuti Patel ji, Distinguished Professor, IMPRI, and Dr. Manorama Bakshi ji, Director and Head of Healthcare and Advocacy, Consortia Advisory, Founder and Director, Trilok Raj Foundation, TRF, Visiting Senior Fellow, IMPRI. This program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The distinguished expert panel for day 3 includes Dr. Padma Deosthali ji, Director, Sexual and Reproductive Health, CREA, Formal Coordinator, SEHAT, Visiting Senior Fellow, IMPRI. Dr. Anuradha Sovani ji, Psychologist and Psychotherapist, Professor and Head, Department of Psychology, CNDT, Women's University, Mumbai. Dr. Aqsa Shaikh ji, Associate Professor, Community Medicine, Hamdard Institute of Medical Sciences and Research, New Delhi. The panel of conveners comprises of Dr. Simi Mehta ji, CEO and Editorial Director, IMPRI, Dr. Arjun Kumar ji, Director, IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and efforts into learning and understanding emerging issues pertaining to women's sexual and reproductive health, while helping us to bring together the practitioners and participants through this course for impactful policy research and action. We have also shared the course outline and reading resources in your email. Before we start today's session, I would like to remind you the housekeeping announcements once again. Please join the meeting on time. There will be question and answer session after each presentation. Share your questions on the question and answer box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments in the question to save time. Now, without any further delay, let us start with our program. It is my honor and privilege to invite our co-chair for this program, Professor Vibhuti Patel ji, to start the program with her opening chair remarks. I welcome you, ma'am.
Thank you, Tanu. And first of all, I would like to express my heartfelt thanks to Dr. Arjun Kumar, Dr. Simi Mehta, Ms. Priyanka Neki, Ms. Vaishali Singh for putting this course together for past 1 year. Preparation had been made. Dr. Simi Mehta had suggested this topic and they said there are a lot of interest in this subject. And finally, we had this program. The first 2 days were very exciting. And first day when the Prof. Ramanathan, she started with the keynote address. She clarified the perspective and concepts and constraints and some of the unbundling of some of the most controversial issues in the reproductive health and how the paradigm shift from reproductive control to reproductive autonomy and reproductive rights happened. That whole journey of last 70 years, she unpacked. We had Professor Vina Vaswani, who spoke about the comprehensive maternal care from pregnancy to postpartum based on her experiences in rural Karnataka, peri-urban and towns as a medical practitioner. And third presentation was equally mind-blowing, was by Dr. Padmaja Samant-Mavani, who talked about some of the totally untouched and gray areas such as understanding of the sexual health, human anatomy, navigating consent, some of the legal complications that women face. And also she clarified that when we talk about gender and health, it is not only about men and women, boys and girls, but we go beyond gender binary. Yesterday was a very sensitive presentation by Dr. Kamaxi Bhate, who spoke about guiding adolescent health and nutrition well-being. And we know that she has been active since the mid-80s, working in the bastis of Mumbai as a medical officer, along with 6 or 7 intern doctors. She started this work in the mid-80s, and her rich experience of working among the urban poor and rural areas of several parts of our country reflected in her speech, and so many anecdotes and vinyas and case studies she put forward. Also, as a member of Internal Complaints Committee of Bombay Municipal Corporation. Dr. Anapika Priyadarshini's this thing was conceptually powerful. She also talked about gender performativity, and she talked about Juliet Butler and adolescent changes that take place in body, mind, psyche, self-perception, self-concept, and the societal attitude towards adolescent based on her fieldwork and qualitative study of Bihar. Third presentation by Dr. Swati Rane was about the menstruation, the myths about menstruation, stigma, and some of the alternatives that she suggested. And her study was of the college girls in Mumbai city. And she also shared the findings, and she said anemia is also a major problem. And all these 3 presentations resulted in a very, very lively debate, because participants themselves are also grounded and they are doing actual work in the area of either public health or as a counselor in the NGO or community-based organizations or the rural programs. Now, today's focus is on gender, sexuality, reproductive wellness, mental health, elderly care, the sexual health of elderly people, and reproductive rights of transgender persons. So we all start with the premise that gender is socially constructed, and one's innermost concept of themselves as a man or woman, boy or girl or non-binary person. People define their gender identity in a variety of deeply personal ways that can include either as a man or a woman, but can also extend to identities such as agender, gender fluid, gender non-conforming, and so many other in the gender spectrum. Sexuality encompasses all aspects of sexual behavior, including gender identity, gender orientations, your sexual orientation, your attitudes, the kind of activity you are involved in. And sexuality refers to who a person is attached to and can include a plethora of orientations. It can be LGBTQIA+. While being a gay or heterosexual or bisexual are perhaps the most well-known sexual orientation, but there are so many other orientations also, such as asexual or pansexual. So we need to go beyond gender binary and also think about and understand the whole gender spectrum, about which even the medical professionals or the social activists or people who are policymakers are not aware of. You must be knowing the famous case of a judge in Tamil Nadu High Court said that he was incompetent to give any judgment on the issue of transgender persons' appeal, because he needed study circle, and he demanded that he should be given orientation course on these new issues, which he was not exposed to during his studies and legal career. So improved sexual and reproductive health is a key pillar of overall health, which we saw day before, yesterday and day before yesterday's sessions also. And it's also, we talked about the health of sexual reproductive rights as a human rights. And another major question that we are facing, both male menopause and female menopause, and that is another gray area which will be discussed today by a practicing counselor. And the cultural factors, lifestyle, family support, educational level, employment, economic status, marital status, number of pregnancies and childbirth, all of them play a very important role at the crucial stage of menopause. And the question of gender identity and right to sexual and reproductive health, they are also part of extremely crucial human rights. And normative imageries about reproductive capacities and desires of trans people representations about pregnancy and womanhood, and the form taken by identity politics in contemporary feminist movements. I think these are the issues which demand serious debate. So, adoption of reproductive justice approach of challenging binary metrics while working on sexual and reproductive health and rights is a need of an hour. Thank you very much.
Thank you so much, ma'am, for setting such a positive tone for this course. Now I'm delighted to call upon Dr. Manorama Bakshi ji, the co-chair of this course, to share her opening remarks with the audience. Welcome, ma'am.
And good evening, everyone. Good evening, Chair. I think Chair has set the tone because she is so much, eminent and prominent. And when it comes to so much expert on gender issues, she has set the tone so well. But as we convene today's session, I think it's paramount important to acknowledge the critical intersectionalities we have of the mental health vis-a-vis when we talk about the menopause, or even talking about, we have seen in India, like there was a study wherein it was found that the mental health issues were very much almost up to 24% in antenatal care of women, as well as 26% when it comes to the postnatal care. So in this context, in this broader context of gender and reproductive health, by integrating the mental health component into menopause and women's health discourse, I think we are not only addressing the biological transition, but we are setting firm footing to confront social stigma and inequalities. And today's session is going to be very much interesting because we are talking about the rights of the transgenders, rights of the other genders other than the binary. So I think that it's better to listen to the experts, and then I can set my own opinions. Thank you.
Thank you so much, ma'am, for your kind remarks. So now I would like to call upon Dr. Padma Deosthali ji to start the program for her keynote address on the topic Healthcare System and Gender-Based Violence. A very warm welcome, ma'am.
Thank you. Thank you very much to Dr. Vibhuti Patel and the IMPRI team for this opportunity. Really grateful to be part of this course, and it really looks interesting. And I've heard the day one proceedings, very engaging conversations that you've all had. I'll quickly get into the core content here. And I hope we have time to also discuss one or two case studies. I hope the slide is visible.
Yeah, okay. Slideshow mode.
I'll do that. Fine. So, yeah. So we'll quickly look at, the topic now is to look at what are healthcare systems and gender-based violence, and look at the linkages and role of health professionals and health care systems. When we talk about gender-based violence, just to be sure that we are on the same page, we are talking about violence that is perpetrated based on gender. So it could be against women and girls, it could be against sexual minorities, it could be against boys and men because of specific gender roles that or certain social norms or communal caste attitudes that may exist. So, the social norms that determine and the gender structure. So those are the kinds of people who may be affected by gender-based violence. Violence against women, of course, forms the largest part of gender-based violence, and this includes intimate partner violence, which is violence by an intimate partner, and domestic violence, which is violence by intimate partner and any other family member. And then sexual violence is again term that constantly comes up, which could be penetrative or non-penetrative sexual assault. So this is what we mean by when we are talking about gender-based violence. When we talk about healthcare systems and GBV, it's also important to note other forms of violence which may have come up in the first 2 days of this discussion, but we will not be focusing on them, but I will be just flagging them. Forced sterilization, forced abortions, and especially against those from structurally excluded groups, such as women and girls with disabilities, labor room violence, these are other forms of violence that healthcare systems perpetrate against the users of the healthcare system. But that requires a different discussion. And today we will be talking about gender-based violence faced by those who are reaching the healthcare system and what then can be the role of the health systems. Why are we saying that health systems have a responsibility? Because survivors, victims may come to the hospitals or may be brought to the hospital. These could be survivors of domestic violence, rape, police torture, or any other form of violence. And they will come for treatment. They may not come there to report violence, but they've come there for treatment. They may or may not report violence, but definitely require support and care for the health consequences. And therefore, health systems can play an important role, both in terms of providing treatment as well as psychological support, and referring them and connecting them to other violence against women services. If we look at what the global evidence says about how it impacts women and girls, those who are experiencing any form of abuse are twice more likely to be experiencing depression, 16% more likely to have a low birth weight baby, and 1.5 times more likely to experience any kind of sexually transmitted diseases. 42% of women who are experiencing violence are likely to be reporting injuries. And 38% of all murders of women globally are perpetrated by their intimate partners. So this is evidence by the WHO. The citation is here. And that kind of tells us why it is so important when we are looking at a course on sexual reproductive health. When it comes to the legal responsibilities of healthcare providers, the domestic violence law, the dowry deaths, the provision, the dying declaration, all of them mandate that healthcare providers have a responsibility in terms of providing care and providing free care. And even in terms of the dowry deaths, it's very clear that the doctor is supposed to certify that the person, if she's dying, she is in a position to give her statement. There's also a legal mandate on a doctor that if a magistrate is not available to record a dying declaration, the doctor on duty can go ahead and, record a dying declaration. Then I think everybody knows about the rape law and the fact that there is a right to health care, right to treatment for all survivors, which is now enshrined in the Criminal Law Amendment of 2013. As well as the POCSO, which is for, prevention of child sexual abuses. And that also clearly mandates right to treatment and care. So the role of health professionals is to identify abuse, recognize that what's coming to them is violence and not just treat the presenting symptoms, document past and current episodes in the given formats, the medical legal formats or the domestic incident report, provide immediate medical support and emotional support and refer them to, qualified violence against women services. The WHO in 2013 has come up with an acronym to say what the WHO mandated role is as far as health systems and health professionals are concerned. They call it LIVES, where L stands for listen. So they mandate that the health worker at any level of the health system must listen to the survivor, listen and ask, what the person is saying, what is the history being given, inquire about her needs and concerns, validate her experience. So, not admonish her for what has happened or blame her, but validate her experience of violence, enhance safety by actually assessing if it is safe for her to go back, what can she do to keep herself safe, and also S, support, which is to, link her up to other support services. So this is a very clear now recommendation from the WHO. And so there is a legal as well as a policy mandate for health professionals to respond. What are the barriers? So if all this is well stated, then why are we discussing it? We are discussing it because it's still not something that health systems respond to. violence against women does not fit the typical biomedical illness model. So it is still perceived as a social issue, not something that as medical professionals, they should get into. It's always considered as a personal matter, a private matter. At the most, it is a police issue, but not something that medical systems can do anything with. There's also a lack of institutional support. So it's left to individual doctors often. And it's only in 2017 that the health policy in India has recognized that responding to violence against women is absolutely essential. Apart from that, there are provider attitudes. So, they feel that this is, violence in the home is part and parcel of married life. She must have done something, that's why she was beaten up. Or they hold this belief that this only happens in certain minority communities amongst the poor, uneducated. When it comes to rape, there is this feeling that most complaints are false. And there are also all these provider attitudes are also rooted in the kind of medical education that exists in our country. These are just three examples that I want to place before you. There are many, and there's a lot of resource which I'm sure is part of the compendium. But basically, the forensic textbooks describes that the chapter on rape describes types of women who can or cannot resist rape, which is absolutely unscientific. But it puts it forward as if it is some kind of very scientifically sound evidence. It actually says that you can determine whether a woman is habituated to sex just based on the examination of her vaginal orifice, labia majora, how it looks, what is the size and shape of breasts and clitoris. So this is there in medical textbooks. When it comes to burns, burn injuries and, dowry deaths has been something that everybody that is what galvanized the entire women's movement in the 80s. But the forensic textbook has no mention of domestic violence or dowry deaths when it in its chapter on burns. And it actually describes a classical example of homicidal burn as suicide. So, it goes on to describe that if you find a dead body of a woman who has been burnt and there's cloth in her mouth, that indicates that she herself, it is a suicide because she didn't want to scream and therefore she put the cloth in her mouth. So these are the kinds of, textbook content which is responsible for the kind of attitude or apathy that they have towards violence against women. There are also a lot of myths around medical evidence in rape. And just to kind of quickly summarize here that after a rape, the rape examination is expected to pick up trace evidence from the body of the woman. It could be semen, spermatozoa, dust, paint, whatever. But that will be possible only if she has come immediately or within a couple of hours, like within certain things may just wipe out in, with urination or after taking a bath, or some, other things may not be found on her body beyond 3 days. So the gap between the sexual assault and the examination is likely to wipe away these trace evidences. Apart from that, the nature of sexual assault becomes important to determine what may be found on her body. So if there's no ejaculation, you cannot find semen. So absence of semen doesn't mean that she was not raped. There could be use of condom because rapists are also smart and they don't want to leave any trace. So these are different reasons why there could be no evidence on her body, and therefore finding no medical evidence does not mean that there was no sexual violence. There's some evidence, and especially in the context of SRH, this is evidence from Dilasa Sehat's work over the last more than 25 to 30 years now. One is that health systems become an inevitable contact for young women because childbearing women are going to come in contact for delivery or for pregnancy, for contraception. And therefore, the evidence shows that almost 10% of women who have, on an annual basis, 10% of women registering at these crisis centers in hospital were pregnant when they registered. And 72% of women at these centers have reported violence during pregnancy. So in the past, they have said that they did experience physical violence during pregnancy. The evidence also shows that health systems can identify abuse at an early stage. So, within 2 years of the onset of abuse, they have been identified. Apart from that, attempted suicide or accidental poisoning, almost 20% of women registered at these centers had come to the center after an attempted suicide. So, therefore, the health system's intervention becomes absolutely crucial. To conclude, a sensitive response from health professional aids healing of survivors. Responding to violence against women must be integrated at all levels of the health system. And explanation of absence or presence of injuries and evidence can be key to accessing justice for survivors. There are, of course, some pressing issues. We may not have time to discuss them threadbare, but it's important to note them, that mandatory reporting laws in our country are a violation of right to treatment, because it does not allow an adult person to take a decision of whether the person wants to enter the criminal justice system or not, or even for children. And it makes it mandatory for health professionals to report to the police at the cost of the survivors actually leaving a health facility, because they have not yet made up their mind what they want to do about the violence. Married women reporting marital rape continues to be a challenge, and transgenders, boys, gay men reporting sexual violence find it still difficult, although the guidelines provide guidance on how to respond to them. But there is a huge barrier because of the health system's attitudes towards transgender and sexual minorities, where health system itself is continues to practice conversion therapies, and it's not at all trans-inclusive, the medical system, and therefore they find it very difficult to access care. I'll stop here, and we have 10 minutes, I hope, so we could I thought we could do 2 case studies so that, participants can actually take part and apply what we have discussed to some extent.
Yeah, thank you so much, ma'am, for such an informative presentation and your session. The floor is now open for questions.
It's a case study she's discussing.
Yeah. So
Oh.
I hope everyone can read it on your screens. I'll read it out so that we don't waste time. There's a woman who reports to a doctor who is a gynecologist during her antenatal care checkups that she sustained the cigarette stubs, burns, and scalds as a result of constant abuse by her husband, who was pestering for a male child. But the doctor ignored it, as she felt she should only be concerned about the antenatal care. After a few months, ABC attempted suicide by use of insecticide, unable to bear the abuse. So if you could either unmute or put in chat what, according to you, was the role of the doctor. You can raise hands and, you can unmute and speak, or Tanu, if you can help me with that.
Yes, ma'am, sure.
Who has raised hand?
No one.
Participants can either unmute yourself and answer this.
There's nothing wrong or right. What do you think what according to you, is the role of this doctor? Do you think the doctor was right in only focusing on antenatal care? Because, I mean, she came for only antenatal care. So why should the doctor get into what is happening in her house? I mean, just say.
Lakshmi ji has,
Yes, Lakshmi Chetri ji has written
you
something.
can unmute and speak, Lakshmi ji. You are also working in rural Assam.
And Neelam also wants to respond.
Yeah.
So we can hear them.
Yeah.
Okay. Yes, Lakshmi ji, you can go
so
ahead.
am I audible?
Yes, Neelam ji.
Yes.
Yeah, I think I'm a gynecologist practicing for the last 40 years and I have seen a lot of such cases. I think very first time when you are examining a patient like this, you should always inquire what are these, and you should involve the family. The doctor should involve the family and ask about it. Because, this is a kind of violence which is happening to her, and antenatal violence is very, very common. It's not very rare. So even in the educated patient, this is not so rare. So I think should have inquired about it. And once you inquire about it, what these are, then definitely they open up, or sometimes one might feel that this is not your concern. They may say that this is not your concern, but you have to be very, very strong and say that, once I'm examining a patient, part of the problem in pregnancy violence also is me to report. So, I mean, at times I have seen that once you go ahead in communication, they open up, and at times you are able to help the patient. So it's not that it's not my matter, or I should not be intervene in it. So this should not be it is the provider's perspective that how does one feel sensitive to these requirements of the patient. So, when you visit a doctor, I think doctor has this right to raise the question and to inquire about it, and maybe telling the consequences and go further inquiring why this is happening and how can this affect her mental this thing, and how mental peace which is lost and she is mentally disturbed, how can it affect the growth of the fetus inside the womb. So there are a lot of things you can communicate to the patient.
Okay. Thanks, Neelam.
Thank you so much, Neelam ji. Lakshmi
Pardon?
ji, you can go ahead.
Yes. So, like most of the time, what happens is when we visit any doctor, it is said that the doctor, like when we visit the doctor, most of the time it is like the doctor only asks ki kya bimari hai or what is the problem, and the conversation just end up ki pet mein darad hai ya something like that. But yeah, I think here the doctor would have taken the opportunity and would have inquired more. And I think the first thing he would have listened to her, to ABC, and gather more information. What is she going through, or what is she wanting to? If she is willing to, file a case, or if she, I think the doctor would have referred her to the legal system, or provide more counseling or any other support. I think that was the first thing he could have done.
Yeah. Yes, Lakshmi.
Thank you so much, Lakshmi ji. Yes, ma'am. Chetali ji has raised her hand.
Yeah.
Chetali ji, you can go ahead.
There are 3 more responses by Rajasi, Saheli,
Yes.
and Amiti.
Yeah.
Rajasi ji, if you want, you can unmute yourself. Okay, so Rajasi ji is saying doctor could have involved family and show some sympathy. It may be tricky, but they could have intervened.
Okay.
And Saheli.
Yeah, Saheli ji.
Hello.
Yeah. Please go ahead.
Hello.
Yeah.
Yes.
So actually, I don't work in that space, so it's not exactly my opinion to say that. But just as someone who works with women, so I feel doctor could have tried, and if they were in such tricky situation. They could have reached out to other people also for help. But also some other participant who shared after me, it is also difficult. I mean, they are a human being themselves, so probably even they may not have the means to do that, or they may not have, they also get scared in such situations. So that could also be one reason. But yes, of course, intervention could have happened, and we could be after intervention that victim could have been saved.
Yes,
Okay.
thank you so much, Rajsi ji.
Saheli Chaudhary.
Saheli ji has said, could have involved the local police, women's grievance cell. Okay. Next we have
Amiti Chestulia.
yeah, Amithi ji. If you want, you can unmute yourself and say this.
Yeah, good evening, everyone. This is really a pertinent question you have
Can you
asked.
introduce your work, Amiti ji?
Hello, this side Amithi Jasrotia. I am working as assistant professor in Department of Sociology with the University of Rajasthan. As I have said, mentioned the first day that this field is new to me, and I've also entered this field 2 or 3 years back when my student has started working on this particular aspect. And as per this particular case study you have asked, it's really a very pertinent, very important question. See, I'm being a teacher. What I have mentioned in the comment also, at one hand we are doing our job, and another hand we are human being. So we should not forget that human touch and human feeling should not be lessened by any chance. Sometimes we also, as a teacher, like you as a doctor, had to face lots of situations and circumstances when that is actually a real situation. But sometimes we as a teacher also face lots of situations and circumstances when we found our students are from very particular various backgrounds. When they came with their problems and circumstances, we help them beyond our profession also. So if we can do that, and by our professions we can, if we can contribute to the society, what else would be the better for tomorrow world. So that is what I thought of. Thank you.
Yeah, very rightly said, Amithi ji. Anyone else who wants to answer?
Or we can sum up and we can move to another scenario. So
Okay.
thank you everyone for responding, and it's great to have Dr. Neelam here, and she's a professional who could probably relate to this much better. Just couple of points for us to remember: that violence in pregnancy is real. So it's not something that does not happen. Pregnancy does not protect women who are in abusive homes. It actually continues during their pregnancy. If you read this case, you'll find that there are visible injuries on her body when she has come for treatment. Also, she's saying there's pressure to produce a male child, which as per the domestic violence law is a form of emotional violence. So it's the law in our country recognizes it as a form of domestic violence. And therefore, it becomes important for them to respond. And also, lastly, to remember that violence does not stop on its own. It, in fact, increases in intensity and frequency. And therefore, it's important to stop or intervene or refer at the earliest, because here you see that she's come in for treatment and then she's attempted suicide. So it can only become, it will affect and it will only increase in intensity and frequency. So thank you very much. Do we have one more? Can I take Vibhuti?
Yes. Yes.
So, yeah, okay, thanks. So this is another situation. Post-communal riots, the local hospital is conducting a health camp in one of the city slums. Several women report to the doctors that they were beaten and sexually abused during riots by male members of the other community. They reported genital injuries, infections, nightmares, panic attacks, body aches, depression, self-harm tendencies, amongst others. What should these doctors who are conducting this health camp do?
I would encourage our participants to answer. Yes, Arhita Biswasji, you can speak. You can unmute yourself. Arhita Biswasji.
What is my name here?
Rinchin?
Rinchin has.
Yes, Renchin.
Rinchin.
Renchin-ji, you can go ahead.
Hello. Am I audible?
Yes.
Yes.
So I feel out here what the doctors could do is the doctors could refer the women to mental health counselors or some psychologists to take or therapists, because I feel they are in dire need of some counseling. So that could help in some way or the other. And that is, I think, the first step a women should do in such case.
Okay.
Thank you.
Yes. Okay, so we have Shreya ji. Shreya ji, if you want, you can unmute yourself.
Hi. So I feel the first and foremost responsibility of the doctor should be to provide the necessary first aid and both what's necessary to address the physical injuries as well as the mental health aspect, as the previous speaker said. I also feel that in a lot of these cases, it would trigger the mandatory reporting obligations under the I don't know the equivalent provision under the new codes. But under the CRPC, there was an obligation that they should provide immediate care and report to the police. Although to what extent it was enforced, I would not know. But I mean, subject to correction, I feel that should trigger the mandatory reporting obligation. So the doctors should report such cases to the police as well of sexual abuse. Yeah. Thank you.
Yeah. Thank you so much, Shreya ji. Anyone else?
I think during 80s, like when I used to be in the investigation of rape and gang rape as well as sexual violence, the first and foremost, we had to take her for the sexually transmitted diseases. This thing for the medical test, had to be done in every case. I don't know whether it is still there or not.
Yeah. Yes.
STD and HIV. Yeah, absolutely. That during the 80s, it was mandatory.
It is now. It has to be given. In fact, prophylaxis has to be given within 24 hours.
Yeah. Anyone else? Or should we wind up?
Yeah.
Okay. So thank you everyone for participating. So a couple of things. This is a situation of, a situation of a health camp post a communal riot. So we have to be aware of the political context there. And therefore, the role of doctors here who are conducting this health camp, as rightly you all have said, all of you have said, immediate treatment, including, for STDs, injuries, mental health, that treatment becomes absolutely important. Second part is to create a safe space, because it is not something that you can just go ahead and report, because this is it is in a communal riot situation. Therefore, creating a safe space, bringing in counselors who can create that safe space and talk to women, document what is happening, and then based on their consent, take the next steps of what they would like to do as a group. And that becomes very important. One of you pointed out about mandatory reporting, and mandatory reporting to the police for health professional is absolutely clear as far as POCSO is concerned, which is less than 18. But for adult women, we need to emphasize that it should be with the consent of the person. But yes, mental health. So treatment, is absolutely the focus that needs to be. So for the doctors and team to understand that this is being reported, and therefore some kind of a group counseling or a safe space needs to be created so that women are able to heal from whatever abuse and sexual violence that they have experienced. I think Padmaja wants to say something.
Yeah.
Thank you.
Can I take a minute?
Of
Yeah,
course.
please.
Yeah. Padma, thank you so much. And
You can also make your video on.
yes. So
Participants.
what I understand is one important thing is creating a documentation, because at that time when that earlier case, for the first case where the pregnant lady comes to the hospital, she may not be in a position either mentally or domestically appropriate situation where she may want to fall back on legal recourse or whatever. But if she has a documented evidence of injuries, the cigarette burns, etc., which you mentioned, it really benefits her to show in the police station, and that becomes sort of an evidence. So that is very important, and doctors should not hesitate in writing down exact nature of injuries, and her statement, her narrative. All this is very critical, and generally doctors miss out on writing appropriate history and corroborative findings. Both are very important, and many times women come only to gynecologists. They do not come to police. They do not go to any other surgery or ortho or anything. They come to gynec because gynec examination is a private examination, and they feel they are more comfortable talking to gynecs.
Thanks, Padmaja.
Thank you so much, ma'am.
Thank you.
Thank you.
Thank you so much, ma'am. Do we have some questions?
Manorama, would you like to respond?
Ji,
Go first. Yeah.
Ji, madam. As per the Ministry of Health, with these things, these issues had come up. Whenever we used to go and check in the labor rooms and all that, these kind of issues were coming up. And at that moment, ASMD had already mentioned that there are some of the hospital settings, they were having the protocols and guidelines, like how to identify if it's a gender violence, if these kind of bruises are there. And we were expecting, and there was some kind of initiative that at the Ministry of Health level, they thought of building the capacities of healthcare providers as well as ASHAs also, how to identify that there is a gender violence, or in this case, as madam has mentioned, I think what healthcare provider could have done if they found out the signs and suspicion of this, that there were cigarette butts here and there, I think they could have sensitively spoken to the female, and they could have another thing they could have actually done, because most of the places will have the ASHAs in place or community mobilizers. If they had that access, at least they could have spoken to ASHA and further probed, like, what is this? Is there some issue that is happening? Because ASHAs are very close knit with all the families, and just 1,000 people they have the catered. So routine screening for the gender violence and bruises, actually health care providers can detect these cases initially. And additionally, that needs to be trained actually. That is what Ministry had initially initiated, that we will train these healthcare professionals, ASHAs, ANMs about trauma whenever there's these kind of things happening. So as of now, since I left ministry in 2017, I don't know how much training and capacity building has been built on this. We were thinking of having actually the audit of these kind of things. If the women come with these kind of issues, burns, butts, or there's domestic violence, there needs to be actually audit of these kind of cases. But I'm not very much sure what has happened following that. As a Tata Trust person, also we had done one case study, madam, that was about the cost benefit analysis. And that was done with the Copenhagen Consensus Center. And it was found out not only globally the violence of this sort of gender based violence, it is actually giving the cost benefit analysis and the dividend. It costs the world 25 times more than all the wars and terrorism. So that is actually the overall implications it can have on the economies and social well-being. And this research was, madam, done by Copenhagen Consensus, and Tata Trust was partner to it. And this study was done also in Rajasthan and Andhra Pradesh. So that is the kind of impact the gender-based violence can have. Thank you.
I might say that it is the most devastating occupational hazard of the 21st century. And with massive changes happening due to globalization, the major burden is borne by women, and 40% absenteeism at work is also due to gender-based violence, domestic violence as well as sexual.
And unfortunately, madam, out of this pocket expenses for, these kind of mental issues and all that is more than 45% in the countries, our low middle income settings. That's another thing.
Yeah.
Thank you, ma'am.
Okay, thank you so much, Padma ma'am, for such an informative session and presenting such an interactive case studies. And thank you so much, Vibhuti ma'am, for your kind comments. And thank you so much, Manorama ma'am, for your kind comments. Now let's move forward.
Thank you.
Now I'm privileged to call upon Dr. Anuradha Sovani ji to expand our knowledge on the topic integrating menopause, mental health, and aging. A very warm welcome, ma'am.
Thank you so much. And it's always such a pleasure to come and join your group and talk to all the wonderful participants who take a very active and, vibrant part in all these discussions. I must thank Professor Vibhuti, old friend of mine. I think she has more faith in me than I do. So she always feels I will have something to say, although I'm never sure.
Not only
And of
faith,
course,
respect also for the kind
your
of work you
director, Arjun sir, is also very, warm and positive. So thank you all of you for this invitation. I'll just share screen. I have very few slides. I don't really want to focus too much on slides. I want to share here that this is an extremely interesting topic to me personally. But at the same time, I also want to give the disclaimer that I haven't really done major substantive published work in this area because my large focus has been mainly women's mental health and part of that being women's mental health. And I have done IMPRI talks on this before. But I think this is a fascinating area and I really, I'm grateful that we get a chance to talk about this. So the disclaimer is because I do not think I will have a lot of content-rich material to share. I like the speakers who have been there before me and also who will be there tomorrow. But I think we'll all be able to think together and sort of cast our ideas about and start thinking in a new way about how we need to all of us look at women and let women look at themselves more importantly. So to quote, it's also very interesting right now. This is a personal sharing that we are talking here about women and their reproductive health and sexual health. And right now, my younger daughter is here with me with her 2-month-old baby. Today is the 2nd month birthday. So my life is all over the place. Books are shelved. All academic work is right now to the side. And I'm thoroughly enjoying, late nights and sleepless nights and lullabies and all the usual lovely stuff that goes with having a baby. But I also know, having worked in the community, that it is not such a happy place for all the women and all the children that come into this world. And we have had such interesting cases. Just now we heard, looking at it from a medical and a social angle. So to quote a piece from Johns Hopkins Medicine, the journal, the author writes, a woman's body will go through many changes, including those associated with puberty, fertility, pregnancy, aging, and menopause. We know, of course, in our country, in India, there's a lot of deification of the woman. We always talk of woman, the mother, and how like everywhere there is this whole putting the woman on a pedestal and expecting that she'll be able to have 100 hands and do 100 things. And at the same time, not enough care is really taken of her. And then when it comes to all the terrible things that are impacted on her, like all the slides and cases you all saw in Dr. Padma's presentation, which was very fascinating, and also in the ones that went before on the earlier 2 days. What I want to focus on is let us look at all these stages. What I find, and this is both through personal experience, living in the community, watching women's lives, and also through some of the research that some of my PhD students carried forward. So when you look at what happens to women, first, the earlier stages, first of all, we know the birth of a girl child is never very happy event in many families. We have wonderful plays in Maharashtra, like Mulgi Zali Ho, where there was a street play and there was so much activism, where there's no welcome really to a girl child. And why? Right? So that is where it all begins. But then if you look back in traditional societies, the onset of puberty is actually celebrated. And I've seen movies in which, women will be sitting around and they'll be getting the girl to wear flowers and gold ornaments, and the girl who's just achieved puberty and has the onset of menses. And I used to wonder, because it's such a private event. So I used to wonder on watching these movies, how this young girl must be feeling. She was probably already married. And so the whole celebration was because now she'll be able to bring a child into the family, which was the main role for which she was married. And then if it's a male child, oh, wonderful, that's even better. So right from when the onset of puberty happens in the married young girl, underage girl, since then the celebrations begin. And then there is pregnancy. Of course, it's a very happy event. No doubt. Everyone looks forward to having the baby. But there is the whole celebration again, the food, the decorations, the flowers, the gold jewelry, the saris, all the rituals, the celebrations that go with it. What makes one think is what happens if there is no pregnancy. What happens when there is late onset of puberty? We have so many cases, medical cases, where there has been various medical problems. I know other speakers are talking about these, so I will not dwell on them. And then it becomes a huge cause of concern. And because of that, girls are given all kinds of advice. They are told, do this, do that, eat this, do exercise, lose weight. You must really manage your periods well, and then you must get pregnant in time. And so this wonderful research, which one of my students, Megha Tutsian, undertook a PhD research, what we did is, and I want to dwell on this a little, that when a woman for several years is unable to bear a child, when she wants to and she can't, Megha focused on the IVF counseling process. And we all know now that IVF has become a big thing and everybody wants to undergo it. Megha documented, and there was a lot of research internationally and some in India, about what a stigma it was to even go through IVF. And the idea that you need medical help in order to have a child, which was supposedly this very easy process, which all your mothers and grandmothers and everybody went through. We had a very interesting finding. I won't share all her research findings because there isn't time today for that. And that is not our focus. Our focus is more on the menopausal stage. She found that internationally, there is a lot of support groups which are available for IVF, women going through IVF, because it is physically, emotionally, socially a very painful process for them and a very stress-filled process. What we did then is we designed our entire study to focus on intervention in groups and intervention as individual counseling with the couple. To our horror and shock, we found that women are not ready to attend IVF counseling groups. There are support groups for everything. We have, in the community, I've been working with IPH for over 35 years now. We have support groups for all the possible psychiatric ailments, all the various issues such as grieving, such as, loss of partner, so many things. But women were not ready to talk in a group about the experience of what they were going through in IVF. It was very private and they did not want to talk about it, although they knew that the other women in the group would also have gone through the same thing. So we actually had to submit in writing to the university to say we want to make a small change, and rather than an entire group, we will probably have pairs, 2 sets of couples sitting and talking together. That was the only design change that we could do possibly at that stage. So understanding that IVF can be even a worse kind of stress and burden and stigma in the kind of culture which celebrates fertility and pregnancy. Another very interesting story, which I have to share with you since we are going to be into stories in this entire talk. I remember when my first child was born, and now I'm talking about my second grandson. But when she was born, there is this little tradition in our, I don't know if it's there all over India or maybe just in our community, that after the child grows up a little, a month or so, we take the child to some, wherever you believe, like any place which you would like to go and worship. So you take the child there, and when you come home, don't come home straight. You take the child to some other friend's house. The idea was, you're bringing the child out into the community. So my mother asked me, who would you like to go to? And I remember this one lady, my mom's friend, who used to stay in our own building. And I said, I'd like to go to her house, Sucheta auntie. I really like her. She's a wonderful person. My mother didn't say a word. She said, as you wish. Wherever you want to go, we will take your daughter. It happened that this lady had not had a child. She used to look after babies in order to nurture them and make them adoption ready. And she had gotten so attached to one of those babies that she had adopted that baby herself. And that little Radhika was in her house and she loved her. And the society around, the neighbors, they were like, oh, she wants to go to, she wants to go to her house, but she hasn't had her own baby. And my mother knew this, but she didn't say a word. After we came home, I said, Mom, you didn't mention this, no? It never struck me, but you did not. She said, no, it is your choice. You liked what I said. Look, I believe the kind of motherhood she is giving that child, I want to give mine. So it doesn't matter to me whether it's a biological child, an adopted child, what, you see? So these little things are very, very important and they must be looked at. And so, while we are celebrating things like pregnancy and onset of puberty and so on, what happens when a woman goes through being a widow? What happens when the woman starts aging? What happens when she goes through menopause? Nothing. There is no support system. There is nobody to talk to, and there is always this sense of guilt that there's something wrong. Even in Megha's thesis, a lot of women in the qualitative section, they shared that I actually felt guilty when I waited for the monthly period to be missed and it didn't get missed. It's as if I had done something wrong. I went through the IVF process, but it hasn't taken, right? And so I feel I've done something wrong. So here we come to this whole concept of how we also need to bring positivity into all these very natural processes. As Johns Hopkins said, these are natural stages in any woman's life, and she is go through menopause at some point or the other. I want to share at this stage a very interesting little piece, and it's again a funny story. I wrote in Marathi for a small, I don't want to, give it a brand because I don't want to advertise it, but there is this calendar that all of us use in our homes, and we have it in Marathi and Gujarati and Hindi and Bengali and everywhere. So, they wrote to me and they said behind each page, like the first page is the Jan, Feb, March, and so on, the front. And behind there is always a piece. So will you write for that? And we want you to write about women at 40. And again, my mother came into the picture, and how we are. Vibhuti will understand. We are all very, we tend to cast ourselves in a very academic frame. And I said, do I want to write for Kal Nirnay? I don't know. I asked my mother, she said, no, many, many thousands of women read it. So please write in Marathi. And then interestingly, it got translated to English and to Hindi, and I translated into English. And then Hindi, a friend of mine. So I've shared both with you as reading material. But I'll just read some quick excerpts right now for us to understand why is there such a block about turning 40? I think it's great. I think it was a landmark for me when I became 40. The world opened up for me. So a small piece from what I had written. The medical world declares that somewhere between 40 and 50, or perhaps a little later, the woman will stop menstruating, will lose bone density, will lose some cognitive abilities, and naturally lose childbearing capacity, will lose muscle tone, lose hair, begin to gray, look at me, may gain weight, find her voice is hoarser. There is work done to show that the voice changes after menopause because it becomes more male because of the hormonal change. Lose estrogen and suffer all sorts of hormonal imbalances and associated health risks. In reality, people forget what is likely to happen in her mind. They forget the new horizons that may open up for her. The magical change of the caterpillar to chrysalis to butterfly. I'm just reading excerpts. She stops caring whether people find her beautiful because she finds herself beautiful. She stops caring what people will say if she says something, does something, wears something that she likes. She will do it anyway because age 40 sets her free. Her children are grown. She no longer needs to change diapers, go to parent-teacher meetings, juggle office work with packing lunch. Nor does she have to worry about children's scraped knees and runny noses and the husband's office and flight schedules. Sure, she has to worry about the kids' girlfriends and boyfriends, late nights, drinking, safe sex. But then what is to happen will happen, whether she's watching like a hawk or not, and she's very rational about it. She can merrily go out with her friends, not worry if her husband goes off somewhere else because she has more than enough to do socially. She has reached an age in her life, a stage in her career where she is supremely confident of her abilities, has been recognized for her worth and knows it. She has had a chance to do what she enjoys in terms of work, find her identity there. She is now out of the shadow of seniors, parents, in-laws, and authority figures, and in fact aspires to be an authority figure herself. She feels free to enjoy travel, enjoy pursuing hobbies which had been set aside earlier in life, learn a new language, experiment with clothes, hair, acquire a new skill simply because she can. The thing is, do all women do this? Are they able to give themselves the freedom to enjoy this newfound midlife status? Or are they busy bemoaning the fact that their body is aging and they can no longer bear children? Do they believe that they can appear attractive to the world out there? Or do they believe they lack self-worth? So that is what this piece was about. A lot depends on cultural norms a woman has internalized. If society and the culture she grew up in, the family she was brought up in and married into, if she ever married, lays supreme emphasis on motherhood and wifehood rather than womanhood, she is doomed. It is time for every woman to examine her self-esteem, to inspect her role in life, and set goals that she has never dared to set before. It is time she lost some of her inhibitions, gained some self-pride, genuinely believes she is worth it, worth whatever she wants to do. She has to learn to salute herself for all the sacrifices made, all the selfless decisions taken through life so far, celebrating them rather than bitterly regretting opportunities lost. And so on. I had written in this piece, I had mentioned Amrita Pritam, I had mentioned Virginia Woolf, all these lovely women who actually said it out there at a time when it was not really very easy for people to accept such points of view. So let's move on with some of the other things that I want to share with you. In the institute where I work, the Institute for Psychological Health, we have this program which we conduct, which is called BAHAR. And I'm going to end off the entire session today by talking to you a little about BAHAR, possibly because you can repeat that program anywhere, in any country or in our country at any point, any place, city, in rural setups. And I will share with you a little data from BAHAR, which showed the massive change that can come because of these small community inputs that we gave. So I'm going to end on the note of BAHAR and what we found in a research paper. I've also shared the title and source of that paper in my reading list. But before that, I want to take a small, since anyway we are into stories and your kind audience are allowing me to entertain you with some of them. I do want to share a very, very beautiful film, which I think is a must see for everyone. I'm not going to show any excerpts because we don't have that kind of time in this time slot. But I'm sure if you can search and find it, it's an Iranian director. So that's a whole separate story about how a woman director in Iran came up with this fantastic film. The name of the film is The Day I Became a Woman. It is 3 short films actually, which are back to back, and I'm going to very briefly tell you about them. Then I'm going to pause and let people talk about the thoughts that are coming to their mind at this stage. And then I'm going to end with my BAHAR data. So that's my plan for the remaining 15 minutes or so, which I have. This amazing film has 3 parts to it. The protagonist of the first part is this amazing little girl. She was a lovely child actor. The one whose photograph you can see right now on the screen. She was enjoying life. She was sucking a lollipop, as you see over here, and I'm going to tell you briefly about her. The second story was about this young woman, passionate, full of energy, wanting to participate in a bicycling race. And in the third part, there was this old lady. The shot is not very clear, but in a little liberty that the director took, which is of course allowed for any director, the old lady is sitting on a ship, on a barge, sailing out into the sea. And the same two women, the little girl sucking the lollipop and the woman who was riding the bike, as you see with their backs to us, they are watching her float away, which is not possible really because they were three separate stories. But let me briefly tell you, it stayed with me. I've watched this film, I think, more than 3 years ago. In the first part, this little girl is about to turn 12 years old. And the mother tells her that now you're going to turn 12, so you are now going to be a woman. Okay, so now you have to stop doing all this. She has taken these lollipops to a little boy who she plays with every day on the beach. Mother says, you can't do this now because now you've become a woman. So you at 12 p.m., 12 noon today, you are going to turn 12 years old and you're going to become a woman. So you have to start wearing that hijab. You have to cover your face, wear this whole black entire cloth, covering your whole face and body. You cannot go and play with other children. You cannot suck a lollipop and go play on the beach. And the little girl says, but Mama, how will I know when it's 12 noon? How will I know when to come home? Because you're telling me. And the mother sticks a stick into the sand and she says, when the shadow of the stick is no longer visible, that means the sun is overhead, that is when you become a woman. It is so heart-rending. And this little girl goes running around calling her friend and saying, come to play with me fast because there's very little time now. The shadow has become so short. Now it will disappear and then I'll become a woman and then I won't be able to play with you. It was so heart-rending. She doesn't understand what it means, what is puberty, but culture, and her mother and her grandmother are telling her, no, now you have this hijab is ready for you and you have to wear it. Very beautiful piece, the first film. In the second film, this young lady wants to participate in a bicycle and you see her passion on her face. Alongside, as you see, there is sand on either side. The road is in the center. Her husband is riding on a horse and he's telling her, leave this race. This is not a thing for women to do. Why are you participating in a bicycling race? Leave it. And she's determined. She wants to go and she wants to win. So the second film is again heart-rending because, you know, the whole tribe and the men and the husband and his friends and everyone are trying to urge her to leave the race. And here you have all these young women participating. The third part, friends, was amazing. Here you have this very, very old woman. The background is that she has lost her partner who was very rich. She was married off to him when she was a child. And now she has this entire estate to her name. She has tons of money and she doesn't know what to do with it. She's all alone. There's nobody in the world. Her children have gone away. She's all on her own. So she collects all these little boys that you see on all sides of the barge. And she makes them come with her to the mall. And you see all those belongings that she has, a big bed and a armoire, a cupboard, those white gowns. Everything she has ever desired in her life, she goes and buys, right down to a refrigerator and crockery and cutlery. And these little boys, they're street urchins. She has paid them some money to help her carry all of this. And they tell her, why do you want all this? Why are you buying it? She's saying, because I can. Right? I have the money and I can buy it now. That is the story. I thought it was an amazing film. When we discussed it in our film festival, a lot of people said, what is really the meaning? I said, think for yourself. You know, I don't think I want to interpret it for you. So, Professor Vibhuti, with your permission, let's take a 5-minute break and just let the audience tell me what is coming to their mind with these few anecdotes, this description of the film, and then we'll move on to Bahar and then I will end my talk.
Yeah. Yes.
Yes, do tell.
I would
Any
encourage our participants to kindly provide few comments on it. You can either raise your hand or unmute yourself and speak.
Yeah, can I speak? This is Neelam here.
Yes,
Yes,
ma'am.
please.
Go
Yes.
ahead.
Yeah, sure. I think it was a wonderful talk. I really enjoyed
Thank you.
Anuradha talking about it. Since I'm a medical doctor, so I would 2-3 points I would like to just add. I think around menopause, a lot of women start thinking like there is a lot of anxiety about their sexual lives, whether they will be able to or not. At times, I have seen the menopausal women, they feel that they should not have any, now sexual needs are over and they should, but at times they are pressurized by the husband to have sex and they feel very ashamed of it. So I think we should tell them that, this is nothing to be ashamed. This is your body. And if there are requirements of your body and if you feel, I mean, nothing to be ashamed of if your children are grown up, that's something else. You have a body and it has its requirements, so it is nothing wrong. And at times, once they attain menopause, they become a lot of myths around menopause, like they will go blind, the eyesight will go away, and if they would have sex, they would have some sort of disease, and they feel very dry because of the hormonal changes in the body. They feel dry and they have recurrent urinary infections, and likewise. But the two other most important things which a woman should be aware of around the menopause from the medical perspective is, one is that she has to be screened for cervical cancer, and the other is after 40, every 3 years, and after 40 for the breast cancer also, as it is rising at a very fast pace in our country. So I think that is something very, very important. Thirdly, I think because of the inhibition, because she has already passed the reproductive age group, so I think any problem related with the genitalia or the reproductive organs, if she has some problem, she is unable to express it to the daughter-in-law or to the daughters, or in case she doesn't have another woman in the house, she may not be able to express it even to her husband. So this has been a problem I have seen that, ladies do not speak about, and they're quite ashamed of that. Why have they got this problem? Because now their reproductive years are over, and what somebody is going to say if they have this problem. So I think at times I have seen the ladies reporting in very late stage of the problem, whether it is cancer breast or because they can't say it because of the mystification of menopause and her reproductive requirements and reproductive tract diseases are not known by appreciated by the others. She's in a stage of silence, and she keeps in silence, and she's unable to say. The third thing that, I'm very happy that, I mean, in society generally, it is considered that you should wear age appropriately, and as a result, even if they are willing to have, I think that also is something like which gives them depression, because you are supposed to feel aged.
Yes.
Because that's the society which feels like ab to aap budde ho gaye, ya abhi aapko ye kyun karna hai. And so I think pressure, these are the kind of pressures which this women feels, and because of a lot of other changes which 20% to 25% of women have around menopausal, which are a lot of mental problems like irritation, hot flushes, depression. So this is another phase of life where I think she needs support, and I think these needs to be explicitly expressed. And there should be talks. We should break silence on these things, and I think people should dialogue on these issues that elderly women do have reproductive needs. So I think these are some of my understanding, and I have seen a lot of women coming into these different things which I said, and I attend patients and I understand. So I think this is something that we have to focus here, and her other needs of bodily, like what sort of supplement she needs, and other that is the medical aspect of it, is I'm going to speak about it.
Thank you
very
so much. I think Dr. Neelam has so effectively underlined all the points, and I'm going to bring each of these up in the discussion about Bahar. Thank you so much, ma'am, and your vast experience dealing with so many patients has come through. I think a very important point she made, which is also reflected in the chat written by Rajasi, that unfortunately sexuality is looked upon only as a pathway to having babies.
Yeah.
And so what Rajasi has written is that women not being celebrated when it's not related to pregnancy and childbirth is heartbreaking. As so many cases around me where they were celebrated when they were pregnant, but literally no one provided support when the pregnancy was lost. Absolutely true, Rajasi. And we do have support groups for women who have, who are grieving the loss of a child, even an unborn child. And of course, people who are struggling to get pregnant. So I think Dr. Neelam has perfectly underlined these issues, that sexuality is completely a different matter. Enjoying sexuality is something every man, woman, or any gender for that matter should have the freedom to do at any age. And it has nothing to do at all with reproduction or procreation. And also, as you rightly pointed out, ma'am, about the cancer prevalence, which is really very, stressful in our country, and women should be very careful about their health. The same is true for bone density and so many other issues that crop up. So I think it's great that Dr. Neelam underlined all these issues and have perfectly laid ground for me to tell you, to share with you what is done in the Bahar group. Anyone else would like to? Yes, Rajasi's
Rajasi.
hand is also up. Yeah.
Thank you, ma'am, for the great talk. And so I wanted to share this incident, this little thing in my family. So there's this aunt of mine. When she stopped menstruating, she became so happy. She used to have really bad periods, like really painful
Yeah.
periods she used to have. And the doctor had asked her, you if you want, you can choose to do hysterectomy. But she's like, it's okay. I'm already in the perimenopause. I will just wait for it to stop. So she waited, and one day her periods just stopped. And so when they stopped, she was so happy. And after that, she started traveling. She started doing things she couldn't do when in the menstruating age, and also because of many responsibilities at that time. So when she became so free, people started, judging her, labeling her that, oh, so now she's becoming a shallow person. Now she has newfound independence. She thinks she has become young again, and all of that rubbish talk family started speaking about her. But however, I was a teen at that time, and I used to admire her, and I used to like, oh, I want to be like that person.
Right. Absolutely. No, wonderful.
Yeah.
And really, why not? I mean, she has gone through a lot of pain, and because now she's free of that, she's free to live her life the way she wants it. So this
Yeah.
concept of Bahar, yes, Padmaja has also would like to say something. Yes, Dr. Padmaja.
Madam, I would like to highlight, since just now Rajasi spoke about probable requirement of hysterectomy.
Yes.
Hysterectomy has become a great worrisome thing as far as slightly older women are concerned, because it's like, appendix and uterus, very disposable organs. And because the schemes are there, actually there are inquiries about the misuse of these schemes, and women are also very easily given to this suggestion of doctors that she should undergo hysterectomy. And I think there has to be a very sort of educated or informed decision by family as well as the woman herself. She doesn't have to give in to the first suggestion that comes her way, just to get rid of the troublesome menses. She is 49 and she suggested hysterectomy. There are so many cases where they come for second opinion to us because we are a public hospital, not really going to make money on these things. But this is a racket actually, which is there in the private healthcare setups.
Yes, ma'am. No, I think I'm very happy you have raised this, because women need to also be educated of how protective this hormone is to them and to all the various health parameters. So in terms of why remove something if you can handle it in any other way. So I think Dr. Padmaja has perfectly highlighted the need to educate that there are certain aches and pains that one goes through at all stages of life. And menses is one of them, menstrual pains and so on. But just to get rid of it, if you get rid of your uterus, you're going to invite a whole lot of other problems because of the estrogen deficit that you create artificially in your body. And there has been a lot of work. In fact, one of my classmates, Dr. Farida, is at Texas, and she's doing amazing work with how this hormonal loss at a later stage is causing so many emotional, cognitive, so many changes to women. Yes, Dr. Padmaja, you would like to add to that?
Even neurological, very
Yes.
significant problems.
Absolutely. And why invite that when you have a long period of protection ahead of you, because those hormones are still going to be around as long as you have your uterus. So I perfectly agree with you. Thank you for that input.
What about the early onset of menopause? So many young professional women as well as working women, even they are saying that in their late 30s or even early 40s.
Yeah, Dr. Padmaja, would you like to respond?
Yes, when there is premature menopause, that really requires to be seen very cautiously, because again, she invites osteopenia, osteoporosis, everything at a very early age. And the neurological and autonomic symptoms also start. And most importantly, it's her fertility also at stake at that age, because women start especially those who are into some career or something, they might have started thinking about pregnancy much later in life. So all this is a very critical balance. And now there are medical solutions to everything, and that has to be sought. She doesn't have to feel that she is either just a baby making machine or she's no good for this. So this is a critical thing that woman has to understand. We actually say that women beyond the two extremes of reproductive age are invisible in our society. So that's a fact of, it's a very sad fact, but it is a fact. And every stage has got its own problems. Premature ovarian failure has to be taken seriously. Now there is social egg freezing. There are so many options that are available, and they should be looked into by these young ladies if they really require. And because if suppose somebody is having, because breast cancers are happening earlier and earlier now, and they require chemotherapy, this, that, everything, whether they require to undergo oophorectomy because they have breast cancer, which is hormone sensitive. And so this becomes very, very complex. So surrogacy is there, egg freezing is there. So many options are there, and they should be actually counseled about those options very in great detail. This is my understanding.
Absolutely. Another very important issue which we find young women telling us is PCOS.
Yes.
College girls are saying that, junior college girls and even working women in this. Yeah.
Actually, to some extent, PCOS is a little overdiagnosed thing, because PCOS has got rigid criteria which are supposed to be fulfilled when we say PCOS as such. Now, obesity is another thing, and PCOS is, they are two separate entities that people should understand. And slight bit of weight and delayed cycles promptly get diagnosed as PCOS. The thing is, most important part of PCOS is lifestyle modification. And this is a very hard way around, but it has to be the only way around, especially for young girls. And medications and hormones is not the first solution that they have to understand. And getting menses is only one part of PCOS, but their otherwise health, the lipid health, the sugar health, the weight health, the joint health, all those aspects are very, very critical for these women who, if they have real PCOS fully fitting the criteria, then they require to understand that it is not going to really go away. They have options for fertility also. They have options for getting it in remission in a sense. And they should be doing it along with endocrinologist, not only gynecologist and dietitian.
Absolutely. There is a very active PCOS support group in Mumbai. I remember discussing with Dr. Shobha Udpi from SNDT and Dr. Rama Vaidya, and they were all very actively trying to propagate exactly what ma'am has said just now, of better awareness and to avoid overdiagnosis of PCOS. And yes, there would be so many issues. A young girl, a pubertal girl, facial hair, body weight, everybody is giving her advice in terms of do this, don't do that. So I think that's a very important point. And Dr. Vibhuti, thank you for raising that. I see Dr. Neelam's hand is up again, so let's ask her. I also like the comment made by Swati in the chat that she's talked about the identity of a woman being overpowered, the womanhood overpowering human identity, and that othering that happens at various stages. I think the emphasis on agency is perfectly handled by Swati in her question, and agency is exactly what I'm going to come to when I talk about Bahar as I end this session. Yes, Dr. Neelam?
Yeah, I just wanted to add to what Padma said. I think one of the important points which probably missed out of it was the cardiac protection which these hormones give you. So that is one. The other, I wanted to talk about this menopause once you this PCOD. One is that we should be like there is very little understanding that the kind of sanitary napkins which are being used. They have some when they are washed to make them white and user friendly, they generate some gases like dioxin and furans, which actually are hormone disruptors.
Carcinogens.
Yeah, they are carcinogen as well as hormone disruptors also. And at times, probably, I think there is, I have not found out any researched out paper which speaks about the correlation between the menstrual irregularity. Some knowledge has come around menstrual irregularity and use of these napkins, which they can have some association. But there is a lot of hormone disruptive activity which is going on. And we did a small pilot here. I work as an NGO also, and we did some small pilot, and we found out that women who were using sanitary napkin, even in today's date, sanitary napkins all the time, and girls who were using in rural areas who were using the cotton cloth. So they had less menstrual irregularity as compared to the women who were using sanitary napkins all the time. And the reason could have been the endocrine disrupting activity, which comes with the use of sanitary napkins and these chemicals, which are furans and dioxin, which are there and they gets accumulated in the fat cells around the perineum. So that is something which is to be, I think, we need to, when we are talking about women and issues, I think this issue should be talked about, because apart from this, I think the kind of waste which sanitary napkins are generating, they are not decomposable, they are not biocompostable. They take nearly 800 years to decompose, as well as they are creating a havoc on the petroleum products, which are not unlimited, or the wood pulp out of which they are made. So these are natural resources. So I think we have a lot of connection with when we talk of environment and climate and the sanitary napkin, as well as the women's health. So I think this is, of course, this is little digressing from the issue, but these are the real issues which only women use the sanitary napkins. So this should also be a consideration that can be considered some other products, or awareness on using a more climate friendly and environment friendly, or nowadays they have started calling it green menstruation. So I think these are also issues which should be talked about once we are talking about the women's health and women's issues.
Thank you, Dr. Neelam. Rajashi's hand is still up. Would you like to add something more, Rajashi?
No,
Okay.
I'm done.
Okay, thank you. I think my time is almost come to an end, and I think baby is also calling. So I'm going to just end with Bahar. Bahar was a concept that came up. Institute for Psychological Health is where I'm currently working, not working for them, but I've always contributed time to them even through my academic career. It's a large social organization here in Maharashtra where we do a lot of community-based mental health work. So Bahar was a focus on women, and that's why I wrote that piece, Magical Life After 40. Women who are reaching that stage, as all the doctors in the group have shared, and they're sort of not having agency. They're sort of sidelined, they're invisible, as you rightly said. their main role of wife, mother, and so on is getting over, and they feel like they're not really important to anyone anymore. And we wanted to highlight in this that if not anybody else, they should be important to themselves. And so we created a series of all kinds of discussions, programs exclusively for women who were either peri or pre-peri or post-menopausal. So that was the criterion, that they should be at some stage around menopause. So that majorly dealt with the stigma of discussing menopause at all, because women hate to accept that, okay, I'm going through that stage. And like Rajasi shared with us so nicely, it is actually quite a liberating stage for many women. And so there was this series of modules which were covered, talking about health, talking about menstrual, the kind of menstrual health one should maintain even during the perimenopausal stage, and also talking about, so that we labeled the program personality development. We didn't want to focus only on the sexual and reproductive aspects, and then also moved into exploring other hobbies, other activities, other talents which the women had, which had always become sidelined because their main role was something different. And to our surprise, we found women were so talented at doing so many things, very offbeat things, and they got a chance to discuss this thing in this group which met very regularly. And there were sessions where we invited gynecologists, invited doctors, experts to talk to them about their body and about their health, and maintaining their bone health, and maintaining their nutrition and exercise and diet and everything. And in that process, these are 3 women. I'm sharing the tables which were based on the findings of that particular program. So in that table, you will see that they found major shifts, statistical changes they found shifting pre to post when they tried to measure areas such as, of course, these are self-rating. So I'm well aware that there could be a large amount of bias, because these women actually felt very good at the end of these programs. And there will be, therefore, some kind of halo effect where they felt when it came to self, as you see in the tables, interpersonal relations with other people, work time pressure. Even if the women were not working in an office or in any kind of workplace, they would definitely be having a lot of work in the home, as they were homemakers. So the first table shows the data for housewives, women who maintain the home, they were homemakers. And the second data, table 2, shows women who go to a workplace. So the home is also their workplace, but they're also going to a commercial setup where they are working and giving their time and their talent. And you do find that there has been major shifts, positive shifts that happened in interpersonal relations, and the way they handled work time pressure. The data itself is not very important to me, because like I said, there will always be some self-report bias that will be there, and that is the only way we could have measured this. I think the point is that Bahar gave these women a space to come and share, to come and enjoy this time together, where they could leave out all the other people in their family and enjoy being with other women and sharing issues which are of interest to other women. It also gave them time to think about themselves. So I think rather than the changes in self-rating, I wanted to look at the fact that they rated self, the fact that they felt okay at the end of all the sessions, the way they rated themselves was much higher. The way they felt their interpersonal relations were going was much better, significantly. The way they were handling work-time balance, work pressures and time balance, work and home, all these things showed a major shift. So I think Bahar is a very simple module. It's not very hard to conduct it. And since we already are very much into film clubs and film festivals, we also shared a lot of films. So even this, The Day I Became a Woman, was shared in Bahar. And a lot of healthy discussion emerged. Another nice fallout, which has not been recorded in this paper, is an old paper. It's 2011. Pooja, Sharmila, and Kusum, who wrote this paper, later also conducted some narrative analysis. The women came and spoke about what they experienced. And they said that we started speaking differently to other women. We started speaking differently to people at home. We started asserting ourselves more, asking for what we wanted. We felt we had a right to say that this is what I want. So what was mentioned in the chat about having agency is, I think, a very big shift that happens with programs like Bahar. And so I feel I would like to end on that note. I don't want to drag well beyond time because I'm sure the next speaker is already here and we're already about 20 minutes late. So thank you, audience. You all have been amazing. And I'm glad that you enjoyed this discussion and it got all of us thinking. And I had a lovely chance to share all these beautiful thoughts and films with all of you. Thank you, Professor Vibhuti, for sharing. Thank you, Tanu, for coordinating everything.
Thank you.
Thank you so much, ma'am, for joining us today and giving such an informative and interactive session. I also thank all the participants for joining the discussion. Vibhuti, ma'am, would you like to comment on this?
No, I think it's a very valuable stories that Dr. Anuradha has shared, and especially because she has worked in this area for nearly 50 years within hospital, within university, with the community, and especially her column in Marathi, for which so much of response is there by the readers and common women, no, like you and me. So I think getting that gist of all that is, we are really honored, Dr. Anuradha.
Thank you. Thank you so much
Manorama ji,
for giving me this opportunity.
Yeah.
Thank you so much, Vibhuti, ma'am. Manorama ji, ma'am, would you like to add something to this?
No, it was such a wonderful presentation, so I don't want to say anything.
Thank you so.
Thank you so much.
Thank you so much,
Thank
ma'am.
you. I'll take your leave. Yeah. Thank you.
Thank you, ma'am. Okay, so let's move forward. So now I'm delighted to call upon Dr. Aqsa Shaikh ji for her keynote address on the topic reproductive rights of transgender persons. We welcome you, ma'am.
Dr. Aqsa. You are muted, Dr. Aqsa. You need to unmute. And switch on your video.
Give me a second.
Yeah.
Okay, so Dr. Aqsa Shaikh ji, Associate Professor, Community Medicine, Hamdard Institute of Medical Sciences and Research, New Delhi, is joining us today. We welcome you, ma'am.
We lost her. Oh, yeah.
Yeah.
Yes.
Yes, ma'am.
Yes.
Hi. Good evening, everyone. Sorry for a minute's delay in joining. And as mentioned, today we'll be talking about the reproductive rights, reproductive health rights or reproductive justice for trans persons. I'll be using some slides for it, so let me just start sharing the screen. Can someone confirm if the screen is visible?
Yes, it's visible.
So I was able to witness the previous session and it was really a very engaging discussion. And we really say that a discussion is good when you do not understand who is the facilitator and who is the participant. So it was really nice to see the wholesome participation from the participants who also brought on the table their own experiences and expertise on the topic. And I hope that also continues for this session. I really invite the participants to come and interact. Now, when we speak about trans people, there has been a lot of conversation going on who trans people are. And fortunately, we do have some idea about trans people. However, often our understanding of trans persons is that of someone who is from a socio-ethnic group like a Hijra Kinnar community. But the transgender umbrella is not only that. And there are many more identities that come under it. And often transgender men are invisibilized because they've not been historically represented. And then you also have non-binary people who do not identify either as a man or a woman in the binary spectrum, even within the trans community. When we speak about laws in India, since we'll be talking about rights which come from the laws, remember that the Indian law or the Transgender Act also includes intersex persons within the ambit of the transgender persons. So when we say transgender persons here, we are also including intersex persons, legally speaking. And it also includes other identities like Aravanis, Jogappa, Jogtis, and so on. A quick stat check, the number of trans people in India. We do not have an accurate number of how many trans persons are there in India, but as per the last census, there were around 5 lakh people who did not identify either as a man or a woman. And 54,000 of them were also children, most probably intersex children. We know that the literacy rate or the educational status of the trans people is often lacking because it's difficult for them to attend schools, face bullying, and then continue studying. And once you do not have education, then naturally there are issues that come in terms of education, jobs, getting rights, securing rights, etc. And that is how trans people therefore survive in our society, which can be in the form of begging or basti badhai. Taking into consideration, a lot of people think that the blessing of a trans person is very powerful or the curse is very powerful, and therefore utilizing that aspect. It can be also through sex work and in the form of performances like dancing, singing on occasions. When it comes to the rights of the trans persons, trans people were not recognized legally under the Indian Constitution or the laws till 2014, when the Nalsa versus the Union of India judgment came. And that was the first time when the Indian court said that beyond men and women, there's also third gender or the transgender persons. And a lot of rights that we have under Constitution would also be inferred to apply to them. For example, the right of expression and gender would be also included as the equality in terms of sex. So the Nalsa versus Union of India judgment had certain key points like right to self-identifying. That means you do not need a doctor's certificate or something to identify yourself as a transgender person. So it gave legal recognition to the third gender, and that's how in all the IDs, etc. now you have the third gender also as an option available. It talked about fundamental right to dignity, and that dignity means self-expression. And this is important to note that previously people from the trans community who would dress as their desired gender would be called cross-dressers and would be punished as having immoral offenses or behavior under the Criminal Tribes Act. It talked about prohibition on the basis of sex, and that sex was extended to also include gender. And it also, the judgment talked about recognizing trans people as socially and educationally backward class of citizens, and therefore forwarding the affirmative actions that the government has in terms of reservations in education and jobs to them. Now, there have been certain very landmark events that have happened in the last 10 years as far as the rights of the trans people are concerned, starting, of course, with the 2014 Nalsa judgment. The Indian Psychiatric Society also released the position statement saying that homosexuality is not a mental illness, that gender expression is not a mental illness. And that's how Section 377 was read down. Homosexuality was no longer considered criminal. In 2019, during the pandemic time, the Transgender Persons Protection of Rights Act was passed by the Parliament, followed by the rules. The act is not perfect, but we still do have the act. In 2021, the Madras High Court said that convergent therapy or any form of therapy that tries to change the sexual orientation or gender identity of a person is medical malpractice and must be banned. In 22, the government included in the Ayushman Bharat package health insurance for trans people, including provision for gender affirming surgeries. In 2022, the MTP Act included trans people, and it expanded the scope from women to interpret all people, irrespective of their gender, who need MTP services. In 23, NHRC provided an advisory on transgender people. Now, when we look at this, it seems that, things are very good. In the last 10 years, a lot of progress has been made, and indeed progress has been made. But then there are also challenges when it comes to the reproductive rights, specifically if we speak of trans people. And as the previous speaker mentioned, that when it comes to sexuality, when it comes to desire, when it comes to expression or acts of making love, they are independent of age, they are independent of gender, they are independent of whether that leads to reproduction or some form of conception or not. And that is something which is also very core to the sexual and reproductive health of trans people. Looking at some of the key points from the Transgender Persons Act and rules that came in 2019 and 20 and how it impacts health. So it said that there should be no prohibition, there will be no discrimination in the healthcare as far as the trans people are concerned. And when I'm talking of healthcare, this can be general healthcare. Like, for example, I'm going for a routine health checkup, I'm going for fever, I am maybe going for vaccination or so on. Then we talked about providing specific health services to trans people, which may include special HIV surveillance centers and also sex reassignment surgeries that people may need for their gender affirmation. It also talked about reviewing the medical curricula so that we can address the health issues of trans people. The courts have previously pointed out that medical curricula is transphobic and queerphobic. And it also talked about providing comprehensive medical insurance to people. These are two very landmark judgments that the Madras High Court and the Kerala High Court gave nearly on at the same time, just in 1 week's gap. And it said that we need to cut down on the queerphobic content which is present in the medical education. And it was really sad. Like, for example, when me or many of the other doctors were also on the call right now, when we had our medical education classes, homosexuality was taught to us as a crime. It was taught to us as a perversion, as a mental illness. Transness was called gender identity disorder. And anything which is a disorder, we try to cure it. Intersex conditions was called disorders of sexual development. And therefore, everything that related to queerness or that related to transness was considered to be either a disease, a crime, or a perversion. Then NMC revised the MBBS curricula, and subsequent to the court orders, and words like, sodomy, lesbianism were removed, and some queer affirming content was put into the curriculum, especially in the subjects of psychiatry and forensic medicine. Though it's a step forward, it is not enough, because holistically we need to teach medical students about trans healthcare and not just restrict them to the textbooks of psychiatry or forensic medicine. For example, when it comes to gynecology or teaching gynecology, or they were talk about PCOS or about hysterectomy, a lot of trans people also undergo hysterectomy. Trans men undergo hysterectomy because they do not want to have menses. Are our gynecologists trained enough to provide shared decision making with the clients on undergoing hysterectomy, or what are the other non-surgical options that they have for stopping menstruation, or for providing contraception or sexual health or cancer screenings, let's say, for example, cervical cancer screening to trans men. This was again a very important decision where they talked about conversion therapy being a misconduct, and NMC subsequently also passed that as an order. Now, this is a very important topic of medical reproductive right as well as of ethics. And that is when it comes to intersex children, especially intersex infants who are too young. And what do we mean by intersex? Intersex people are those whom you cannot put into the categories of either a male child or a female child. We call it sometimes ambiguous genitalia. It can be because of the differences in the internal organs, gonads, hormones, chromosomes, etc. And many a times, because our system is not, attuned to raising intersex children, the parents feel burdened or compelled to force their children to undergo some kind of surgery sex normalizing surgery so that they look like either a male child or a female child. And then they don't have the burden of raising an intersex child. But these surgeries are not necessary for the child. They are not helpful for the child. They are helpful for the parents. But then they can cause scarring. They're literally like genital mutilation for some of the children. And there can be consequences. And very importantly, there is question of consent, right? Because the child can't consent. And therefore, there are numerous judgments that have come now in India regarding banning surgeries on intersex infants, which are not beneficial to them, which are harmful to them. So Tamil Nadu started that. This is now followed by another one, which is ongoing in Delhi High Court. And very happy to share that me and Dr. Satendra went to the Delhi Commission for Protection of Child Rights. We filed a petition to them saying that these surgeries should be banned, and now it's also in the court. Then we have the National Human Rights Commission, which issued an advisory to ensure the welfare of trans people, and that also includes welfare within the healthcare system. Having said this, let's also talk about where the reproductive rights of trans people get denied, and that is in terms of marriage, adoption, surrogacy, ART, MTP, even blood donation. Let me explain this with examples. So when it comes to the marriage, we have all gone through the marriage equality case, which did not allow queer people to get married in same-sex relationships. But at the same time, the same judgment also mentioned that trans people who have binary gender identities, that is male and female, can get married either to each other or to cisgender males and females. But as I showed in the first slide, when we tell transgender people, it also includes non-binary people who do not have either a male or female identity, or trans people, like for example, from the Kinner community, who refuse to identify as a woman. And then the marriage is denied to them under the secular laws as well as the religious laws. When it comes to the MTP, we have made progress now that now the women word means basically people of all gender. And just a couple of days back, the Supreme Court passed a decision in which it used the word pregnant persons rather than pregnant women, and multiple number of times to also include trans people. When it comes to the surrogacy, we know that now surrogacy is regulated by the Surrogacy Act. And it says that a couple is only a legally married Indian man and woman. And the Surrogacy Act denies the right to never married single Indian women, to single men, and to single trans people also. Very happy to share with the participants that the Surrogacy Act has been challenged in the Supreme Court of India. And I'm also a petitioner on it, and we are challenging the denial to the transgender persons to commission surrogacy. So it allows single women who are divorced or widow to commission surrogacy. Then why that right should not be extended to single men or women who have never been married or don't wish to get married, or to trans people? Then you have the assisted reproductive technologies, which we just talked about infertility and the social stigma that is associated with infertility. NERT is a ray of hope for a lot of couples, individuals. But unfortunately, under the Assisted Reproductive Technology Act, which regulates ART now, it talks about couple, commissioning couple, and that has to be an infertile married couple. So there's a lot of social morality check which now happens when it comes to assisted reproductive techniques. And a lot of trans people who had undertaken egg freezing and other kind of procedures now cannot, under the law, take benefit of the assisted reproductive technologies because it's only for couple. And that's why, you have seen, some people, like, for example, Karan Johar take benefit of surrogacy before the act came, but now gay man cannot take that benefit. When it comes to adoption, we have the adoption related regulations, the CARA regulations, and it says that, of course, a single female can adopt, a single male can adopt. And recently in the marriage equality case, the courts mentioned that a gay couple, a queer couple cannot adopt together, which means that they can adopt singly and the other parent does not get the legal right to the child. So in case the parent who has adopted, on whose name the adoption has happened, passes away, then the child again goes back to the state rather than to the other parent. And that can be very tragic. So no joint adoption is allowed. Also, there is a lot of, again, morality check, social check, which is a double-edged sword that can happen. That happens when before a child is given for adoption. And often we see that queer people who are openly queer or trans people are not preferred for adoption. So that can mean that even if on paper you are allowed to adopt, in reality, it doesn't happen, especially since we know that the number of people who want to adopt is much higher as compared to the number of children who are eligible for adoption. And then this is something very interesting but tragic that under the National AIDS Control Program, which talks about blood safety also, to prevent HIV transmission, only low-risk blood donors are encouraged. And in the high-risk blood donors, trans people are included. Men who have sex with men are included. Injecting drug users are included, and female sex workers are also included. Now, while this may sound very scientific and logical that, yes, we don't want high-risk people to donate blood because there's still some risk present, we know that not all trans people have that same risk, right? So if we look at, for example, transgender men, their risk is not same as that of the transgender women who may be a sex worker also. Or for example, you have trans people who are celibate, they're not engaging in sexual activity only, but just because they're trans, they are not allowed to donate blood. Or for example, you have trans people who are in monogamous relationships and still they are considered to be high risk. Whereas a cisgender man who is having multiple sexual partners may not be specifically singled out. Also, scientifically, we know that with the increased quality and number of tests that we have available, we can ensure that trans people are not denied the right to donate. And this is important. You may say, okay, what's the problem if some trans people are not allowed to donate blood? Now, imagine if I, as a trans person who is away from my family, I don't have family support because my biological family has left me, let's say, I get admitted and I only have trans friends who want to donate blood to me. And I'm in need of blood. And if I say that all of them become ineligible, then who is going to donate blood for me, right? So when it comes to trans people who are in need of blood and their trans friends who want to give blood and they being not allowed, and very importantly, by labeling groups like that, you also further the social stigma which is present. We say that trans and queer people have a higher need for healthcare, and by saying that, I mean not just the general healthcare, but also about the menstrual health or menstrual disorders. And we know that transgender men who may have uterus and cervix have many needs which are similar to those of the cisgender women, but they are denied. I mean, you have someone who looks like a man going to a gynae OPD, getting a paper and showing up to a gynecologist is beyond our imagination because we feel these are areas only for women. When it comes to STI, HIV, monkeypox, we know that trans and queer people may have a higher risk. When it comes to gender affirming care, unfortunately in India, there is very limited supply and the quality and control of it is very poor. When it comes to cancer screening guidelines, even guidelines, for example, for HPV vaccination, which is now the buzzword, where are the trans or queer people included in the guidelines? What are the cancer screening guidelines, breast cancer screening or cervical cancer screening guidelines for people with cervix, trans people with cervix? We know they have increased risk for mental illness, suicidal ideation, substance use, and also are prone to conversion therapy. And that puts trans people a lot at risk. In fact, we know that the life expectancy of a trans person is much lower as compared to a cisgender person. And not just the quantity of life, but also the quality of life can be very poor. This is just to show the couple of research papers that we published on our work with the trans community. One of them talked about the experiences of transgender persons in accessing routine healthcare services in India. It was a qualitative study. And we found that there are numerous systemic barriers, individual barriers, healthcare provider level barriers that are present. We also looked at how during the COVID pandemic, it was very difficult for trans people to access healthcare and how that further impacted their mental health. Now let's look at some of the solutions that we can do to ensure that the reproductive health of the trans people in future is taken care of. That would need revision in the medical curriculum. And by that, I don't only mean gynae curricula or forensic or psychiatry, but overall. You know, if a trans person comes for fever, they should also be treated without any discrimination and looking into their specific health needs. And I say this with just one example. You know, you want to diagnose anemia in a person. We know that the cutoffs of hemoglobin are different for men and women, right? It's, let's say, for example, 13 for men and 12 for women. What will be the cutoff for a transgender person? It's a question from biochemistry or pathology, but do we have answers to these questions? What are the values for renal function tests for trans people? So we need more research and more revision in the curriculum. We need CMEs for those who are practicing, doctors who are practicing, and I'm very happy to see some of the practicing doctors on today's call. Making healthcare services trans inclusive, not just in terms of infrastructure and documentation, but also human resource and services, and research and publication, which is done with the transgender persons and not making them like guinea pigs in the process of doing research. We need medical education and healthcare to become more trans affirmative. We do not have a law for ban on convergent therapy. It's only a couple of court judgments. We need a legal ban and punishment or criminalization of convergent therapy. We need ban on medically unnecessary surgeries on intersex children. Again, it's only limited to a few court orders, but no law by the parliament. And provision of quality and affordable services so that a person does not have to suffer just because they are trans person. And all this, please remember that when we talk about reproductive right or health, they do not work in isolation. They have their basis in laws and how legally identity of a person is there. So we need decriminalization, depathologization, and demedicalization. These words are very heavy. Let me deconstruct them. The existence of a trans person shouldn't be criminal. But unfortunately, we had Criminal Tribes Act, Section 377. And for example, some of the acts like blood donation guidelines, which still do not allow us to lead the life that other people lead. We need depathologization, to not think of transness as a form of a disease or disorder that needs cure or surgery. And also to demedicalize transness. By what I mean is that once we think of a trans person, we see, okay, they need a sex change surgery or a sex reassignment surgery. No, a trans person without medical intervention, without HRT, without surgery is also a trans person, and they shouldn't be medically forced to undergo any form of procedures. But if they need a procedure, then that should also be available. And lastly, I want to say this, that whatever good we want to do for the trans people, it's very important to involve them from the decision making, whether it's in the curricular revision, whether it's in the hospital infrastructure, whether it's in making laws. And I say this as an example that the Transgender Persons Act was passed by the parliament, but there is not a single openly trans MP in entire India, right? So cisgender people making laws for trans people without adequate consultation or representation doesn't work. So in every endeavor that we do for ensuring gender justice, we have to ask, where are the people whose identities we are talking about on the decision-making table? With that, I'll conclude with these slides, but look forward to questions and discussion. Thank you.
Thank you so much, ma'am, for raising such important issues and delivering such a well-detailed presentation. Vibhuti, ma'am, would you like to add your comments?
Yeah, I would just like to ask that what are the support system currently available and the initiative which you have started, Doctors for Trans People? Can you just tell us some of the empowering stories of that, and can it be replicable all over the country?
So we do our work mostly with Sangat, and our work is predominantly in the field of making healthcare more accessible to trans people. And one of the components for that is ensuring that the medical curricula is revised. So we are constantly in works with the trans people to get ideas on how to revise the medical curricula with medical educators, with trans people, and also ensuring that this is based on humanities. We don't talk of curricula as textbooks only, but also as experiences, poetry, theater, writing, and how they can be expressed. In fact, after 2 days on Friday, we will be having presentation by queer people who will be giving their first person narratives of their experiences with the healthcare system, how that can be made better. Then another initiative that we are doing is training of the doctors through workshops in the medical colleges, and especially with the young medicos also, because they are really the hope and the future of our country. And ensuring that there is some kind of also a ripple effect that happens with the medical educators and they take it further. Third thing that we are doing is making the medical campuses inclusive. When we look at trans people, they are not just patients, but they're also doctors. They're nurses. We are fortunate to have some trans doctors, nurses, paramedical staff. But as a doctor, nurse, or medical student, their life can be extremely difficult in a medical college, which is not made for them. And therefore, we are trying to look at campus inclusion for queer people who are on the medical campuses, etc., and then for them to become change catalysts in their own institutes. And very happy to say that we have had very good response from especially the younger generation who has more liberal views on queerness or gender identity. I'm very hopeful about the future, that whatever may have been the past, in the future, medical professionals will be more transformative.
Thank you. Thank you.
Thank you so much, ma'am. Manorama, ma'am, would you like to add something?
I think this is wonderful, Dr. Aqsa. You have raised very pertinent subject, very pertinent issues. I don't think I can, I will elaborate further on this. It's a beautifully she has explained. Thank you.
Thank you so much, ma'am.
So much of
Participants
knowledge.
who would like to ask questions, you can kindly unmute yourself.
Nikita Sharma.
I'm audible?
Yeah.
Yes.
Ma'am, why people relate reproductive right only with pregnancy and motherhood? What is the reason behind it? It's a lack of legislation or lack of awareness. Even we know reproductive right contain many other rights. Because I'm working on reproductive right in my PhD topic. When I talk about it, then my friends and other people think that I'm doing only I'm working only on reproductive right, means I'm working on MTP, Medical Termination of Pregnancy Act. So please, ma'am, answer it.
I think terminology plays a lot of role in our understanding of what we do. And once, we look at the word reproduction, that word itself means that we are talking about reproduction of the species, and therefore it comes to conception, pregnancy, contraception, and those terms. And naturally, the burden of that is more on women, or of course, there's contribution from men's side also, but whether we don't talk about men's contribution in contraception or men's contribution in reproductive rights, and unfortunately, they are also denied their own reproductive rights, is what I feel. And now that we are taking the conversation further to all genders beyond men and women, naturally, there is a paradigm shift in the conversations. And therefore, we need to expand and change also our vocabulary. So one example I want to give of how that change in the vocabulary happens is how instead of saying pregnant women, we are not talking about pregnant persons, because there are also transgender men who get pregnant. We now, for example, instead of just saying people as male or female, we have an organ checklist when a doctor sees a person of any gender. So, for example, you say that, okay, this is a transgender person who has cervix, uterus, ovaries, so that I know that on account of those organs, they have certain medical needs that I need to cater to. That, okay, they may need a cervical cancer screening. They are a person with breast tissue and therefore they may need a breast cancer screening. But many times when I say, okay, I'm a trans woman, just say I'm a woman legally because my certificate says woman, the doctor unfortunately cannot understand what are my needs. And it can become an awkward conversation for them to get intrusive about what's inside my body. And therefore, there are these, how you talk about it. So, for example, with trans men, instead of breastfeeding, we use the word chest feeding. We now talk about pronouns and the importance of it. We now talk about chosen or legal names. And these are how, we can change the vocabulary, and how with the change of vocabulary, the understanding also changes. So yeah, unfortunately, the word reproduction itself has a lot of connotation, and sexual and reproductive health, I think, is a much better term.
Thank you so much, ma'am. Ma'am, I want Manorama, ma'am, also throw light on my question.
Well, actually, Dr. Aqsa has raised it well, but yes, there are certain issues like within the ministry also, as Dr. Aqsa mentioned, like trans men and trans women. When it comes to the HIV/AIDS, when we were there in HIV/AIDS, there were certain stigma associated with it. There were like when trans men would come, I mean, they were seen, most of them were seen as if they were HIV positive, even if they would come for. That is why UNDP had come out with like proper guidelines in 2007, like how we can have the programs, how we can sort of educate people about the different groups like LGBTQ. Then we didn't have queer groups and all that at that moment, but that thing was initiated. So I think that going forward, as Dr. Aqsa has said, that we can see a very bright future, because in last decades, so many legal kind of, statements have come forward from the government, and we need to push it further, like with the governments, with the district legal aid support at the district level. We need to, because and we have NALSA, but we have at district legal support also systems we have. So that needs to be further pushed up. And I think that a lot of NGOs and support systems need to come forward, whether we are talking about the LGBTQ rights, we are talking about transgender persons, or we are talking about even the menopause. I don't think in India we have the systems wherein people talk much about these issues, even about the premenopause or menopause kind of women. Prior to this, we had a session, but how many of women? Because I had a neighbor, just next door neighbor, who is 65, but she was hiding her age. She was hiding that she has already undergone menopause, and the whole family was in chaos because of the conditions she was going into. Then we had to counsel her and say that, then actually I gave my own example. I said that I am having these kind of things. I am having a hot flushes, those kind of things. And then she opened up. I said, then I spoke to their families and counseling and all that. But I had to talk about my own things. This is just a year back. Like I had to give my own example so that she can come out with those kind of things. And her family was saying that it was not just within the family, but her work atmosphere, her children and approach. So I think that we as a society need to come forward with different kind of, solutions. And if we are aware, anybody who is aware needs to have that, strengthen those kind of, support systems around.
Thank you so
Thank
much,
you
ma'am.
so much,
Thank you.
ma'am. Ma'am, we have one question from Arhita Biswasji. I'm reading it out. Thank you, ma'am, for the wonderful presentation. In my experience, many trans or gender non-conforming menstruators do not want to buy or receive sanitary napkins or menstrual products in public. For example, in school programs or donation drives, usually menstruation is constantly linked to being feminine in popular discourse. Any idea what can be done for this?
Yeah, so when we talk about menstruation, traditionally, of course, it has been considered to be a feminine topic, with the understanding that only women uh, menstruate, because for us female and women, sex and gender was considered to be the same term. But now we have more trans men or non-binary people who are also menstruating, and therefore there is a need to also include them. Because if you look at the products, the way they are packaged, the color, where they are kept, the brand names, the marketing, everything is done in such a way that it caters only to the female clientele. And therefore, I mean, forget about a sanitary napkin, even if we talk about a face wash or a face cream, if it is branded as a women's product, men will find it very difficult to purchase. And therefore, you have now these black labels or black colored packaging for men's face washes and other stuff. So the same also applies for menstrual products or the hygiene products. And we do have some of the companies who are now going for either gender neutral products or doing a gender differentiation in their marketing strategies and making products available for trans men also. Then even if they are able to purchase a product, the question is how can they safely use it in public places or in public restrooms? Do men's washrooms have facilities for them to change it in a way that it can be discreet, and they don't draw unnecessary attention? Do there are places to dispose of the menstrual hygiene products in men's washroom? And what kind of conversations can happen there? And is it really safe in public restrooms to do that? And then the third question, of course, comes with reference to the menstrual health, that if they need healthcare consultation for that, where do they go? Would a gynecologist in the current situation be competent to handle a male client who is a menstruator? A man who is menstruating. So yes, it's difficult, but then globally we are seeing some changes also in India. And as I mentioned, there's also a lot of rainbow economy. So when you have more trans men who are ready to pay for their menstrual hygiene products, the companies will also make products for them. We have had some of the ads where the people in those ads for menstrual hygiene products are men now. So slowly the conversation is changing, and I hope in future it will change further.
Thank you so much, ma'am. Sahili ji, it would be very great if you could unmute yourself and ask a question.
Yes, thank you so much. Thank you, Dr. Aqsa, for your wonderful presentation. My question is that recently a trans swimmer, Leah Thompson, she is an international level swimmer. She has been banned from competing in the Paris Olympics 2024, citing that she has a higher level of testosterone even after hormone therapy. And that will be disadvantageous for other physiologically born women who has a lower level of testosterone. So in that case, do you think that within the domain of sports, a separate category should be introduced where trans people can compete and where they do not face such humiliation? And another question is, along with this, the hormone therapy, how much is it being successful? Other than producing external physiological differences.
Okay, so those are 3 questions. One is, when we are talking about sports, it's not just only trans persons, but also intersex persons. And we have had instances in India also where some of our sports persons who participated in the women's category, their awards were taken away later on because they were found to be intersex and have higher levels of androgens or testosterons. And as you mentioned, that's humiliation, that's often unfair to them because it's not their mistake. They were themselves unaware of this. Now, when we talk about equality in sports, of course, there is no equality, even if you look at men's sports or women's sports, For example, marathon. If you look at who are the winners of marathon in the last 5 years, a decade, you'll always find it's women from Kenya, Ethiopia, Nigeria. A Japanese woman, for example, cannot compete with a Kenyan woman when it comes to marathon because of the bone structure, the ethnicity, and the genetics. Then can we have different African sports and different Asian sports? right? Even when it comes to, for example, playing table tennis, why is it always the Asians who are winning the table tennis and not people from Africa? Because table tennis is made for people from Asia. You have those differences in terms of height, flexibility, speed, etc. So sports is never equal. Sports is unequal, and we need to understand and accept that inequality and diversity, but at the same time have this foster the spirit of competition. Unfortunately, when the conversations around equality in sports happens, it can stigmatize certain groups, including trans persons and intersex persons. We do know that testosterone can have effect on the body metabolism, etc. But I would ask the participants to refer to a recent study which was published just 2 weeks back. It was sponsored by the IOC, and that mentioned that when HRT is given, then the traditional advantage that people have had in terms of their cardiovascular health or in terms of their bone density, etc., diminishes. And that advantage is lost after a certain period. And therefore, trans women actually have, are lesser in terms of performance as compared to many of the cis women athletes. And this was sponsored by IOC itself. So it's not, I would say it's an area that needs more research and all this thing, but also discussion on the ground of ethics, on the ground of legality. I don't believe that you can have a separate category for transgender sports, because then again, transgender people are not same. You have trans men, women, trans men on hormones, not on hormones, and there's so many categories that will be a never-ending classification, and that defeats the purpose of sports, which is to celebrate just human joy and excellence at the end of the day. Unfortunately, this is spreading not just to swimming, but also to other sports like rugby, which has banned trans people, also to cricket, which has banned trans people from competing in women's cricket. And we will see more of this happening. There are a lot of legal challenges that are in place. And this needs a holistic discussion where trans people should also be involved in the discussion. Intersex people should be involved. There should be physiologists, geneticists, doctors, sports persons, experts, and very importantly, ethicists also in the discussion. So there is no clear answer to it, but yes, we need to work together to ensure that it looks at equity in sports. And coming to the aspect on, are the hormones effective? I would say hormones are almost like magic drugs for trans people. I personally have been taking hormones for last few years and know their effects. And it's not just external, but also internal in terms of your mood, in decreasing your gender dysphoria, etc. And there's been a lot of evidence on how, simply giving hormones to people can decrease their gender dysphoria a lot, can improve their mental health a lot, and can be life-saving for many trans people. But unfortunately, the access to safe hormones in India is not available. Many of the endocrinologists themselves do not know the guidelines for prescribing trans people with HRT. And it's very privileged. You need to pay money to access an endocrinologist, etc. So while medically a solution is available, in terms of public health, the accessibility and other is a challenge. And then we also have the issue of hormones for people who are below 18 years of age, in terms of puberty blockers and the ethics of it. So those are questions that we still need to work on.
Thank you.
Thank you so much, ma'am. And thank you so much, Sahili ji. Any more questions? Melody. Melody ji, you can ask your question. I think it's your surname is Shetri Mayum, if I'm not wrong. You can ask your question.
Hi, can you hear me?
Yeah, yes.
Thanks a lot. Thank you, Dr. Aqsa, for such a wonderful discussion. It's really a very unexplored area for many researchers. My questions are really coming from my inexperienced background in this area. I have two questions, very short questions. The first one is are the trans men the only menstruators among all the LGBT community? And second, according to your own experiences, which methods or interventions could help in including trans menstruators in health policy or menstruation programs?
So, when we come to the terms like trans men or non-binary people or trans mask folks, that's another word that often is used. The words may mean different in different contexts. It's basically people with uterus and people who do not have some kind of a hormonal suppression of their menstruation would be menstruating. Some trans men do undergo hysterectomy or do undergo medical suppression of menstruators, and then they may not menstruate. But yes, trans women do not menstruate. So it's basically either the trans men or trans masculine people or people who are gender non-conforming or non-binary people. And I think one single most important thing that can be done to ensure that our menstrual health policy, etc., is more inclusive of trans men is to have them on the discussion table. Foxy did made some attempt, in having consultation with trans men to look at how the clinics of Foxy members can be made more inclusive for trans men. And I think we need more of those conversations, roundtable discussions where trans men are included on the table. Their needs are taken into consideration and they provide us on those valid suggestions. And I say this, for example, I'm not a trans man and therefore I'm not the best person to, frame those guidelines.
Yeah.
And therefore trans men must always be part of the conversations when it comes to bringing menstrual health equality to them.
Thanks a lot.
Thank you so much, ma'am. Any more questions?
Nikita Sharma has raised.
Nitika ji, would you like to ask something?
No, ma'am. No, ma'am.
Okay. So I thank all the participants for raising such important questions and Aqsa ma'am for answering them. And thank you Vibhuti ma'am and Manorama ma'am for your kind comments. Now let's proceed with the final vote of thanks for day 3. So, as we come to the end of day 3 of Women's Sexual and Reproductive Health Across a Lifetime, an online national summer school program, a 4-day immersive online certificate training course, I, Tanu Palewal, researcher, IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Gender Impact Studies Center, GISC, New Delhi. We are grateful to our experts for day 3, Professor Vibhuti Patel ji, Dr. Manorama Bakshi ji, Dr. Padma-Deosthali ji, Dr. Anuradha Sovani ji, and Dr. Aqsa Shaikh ji for taking out their valuable time and giving an opportunity to the participants to learn from this online certificate program. We thank all of our participants who have raised pertinent questions and actively participated in today's deliberation. Readings for the session have been shared in your email and a video of the session will also be shared with you for learning. We look forward to welcoming you for our last day of the certification course on 9th May at 6 p.m. We are grateful if you're watching us later on YouTube or listening to us on our various podcasts or reading our publications. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you all a very good evening and thank you.